And I thank you again, Dr. Alabadia, for inviting me to present at this Congress. It's been a great pleasure. So my topic today is regarding prompt COH protocols for cancer patients. I divided this into three parts. First, briefly to discuss the goals, the options, and challenges faced by these women. Random start protocols out there, and I will go into them in quite a detail. And finally, what success rates should we quote our patients when they are facing this situation? So the goal of control ovarian hyperstimulation in cancer patients is to obtain maximum number of oocytes, period. Of course, we want to minimize the possibility of ovarian hyperstimulation in these patients. And using an antagonist protocol and LH trigger would decrease the chance of OHSS. The risk of OHSS in these patients is reduced by almost 90% by using this above protocol. So in a sense, one should try to use the antagonist protocol as it also is the shortest protocol that's available compared to the other conventional protocols. The options available to them are to undergo conventional IVF or IVM after random oocyte retrieval. In either case, we can choose to freeze the oocytes or cryopreserve the embryos. Finally, the other option is to have ovarian tissue cryopreservation, which is still sort of in its infancy. The timing of COH is paramount, should always be performed prior to the start of chemotherapy. Any stimulation performed after chemotherapy is poor at best, and there's evidence for that. And the number of oocytes retrieved significantly less in patients, even when the stimulation is performed prior to chemotherapy, it has been shown to be significantly less in these women as opposed to normal patients without a cancer diagnosis. And there are multiple theories regarding that, but we don't know why. So what are the practical issues? The most important issue that we face in managing these women is the phase in menstrual cycle at their initial visit. Of course, the urgency to start cancer treatment shadows that. The age of the patient can sometimes be a problem, presence or lack of a partner, and other comorbidities, especially if they have breast cancer as a diagnosis and if it is ER positive. So, in terms of random start protocols, I would unabashedly say that I have lifted all the following cartoons from this latest publication by Checkmark and Rosen. It's a great paper, and I would urge anyone who has not reviewed that to review it. Having said that, I have considerably changed the order in which these cartoons are displayed because I have my own unique take on it. So again, the guiding principle in stimulating these patients is to use an antagonist protocol. As I mentioned earlier, that has been shown repeatedly to be the shortest protocol, and in these patients, time is of essence. Also, to bear in mind that follicular development occurs in waves. So be willing to sacrifice the lead follicle, and that is within quotes, of the current cohort. And I'll explain what I mean by that in a minute. And start the antagonist only after the follicular diameter of the second follicle reaches a size of 12 to 14 millimeters. And even that may be moot by the time I complete the lecture. So here is a cartoon depiction of the conventional start. So early follicular phase, patient presence in the early follicular phase, or there's adequate time. Patient comes in, wait for menses, then you start the gonadotropins with or without aromatase inhibitor. And when the lead follicle diameter reaches 12 to 14 millimeters, you start the GnRH antagonist, and when you reach a 17 or 18 millimeter follicular size, whatever be your clinic criteria, you give them HCG and or GnRH agonist and go for oocyte retrieval. So that is, of course, what we are used to do, comfortable doing, we like to do all the time. However, patients don't always present at a convenient time, especially if they have hematological malignancies. Time is of great essence, and usually the oncologists don't even want to wait for you to do the egg retrieval. So here comes Anderson's paper from 1999. So way back then, Anderson showed with the preliminary experience of using the antagonist to hasten luteolysis in patients. Supposing somebody is in the mid-luteal phase and you say, well, instead of waiting for their period for another week, let me just give antagonist, cause luteolysis, force them to have a period sooner, and move on with the treatment. And that initial report in 1999 was followed in 2005 by Humaydan's paper, and this was in poor responders, but just that had many more patients in the study. So a multi-center prospective trial where they used 3 milligrams of cetrotide on the 23rd day of the preceding cycle to cause luteolysis, and then on cycle day 2 start FSH and do a conventional antagonist protocol. So in this particular model, patient comes to see you with a diagnosis of cancer. She is in the mid-luteal phase. Give her GnRH antagonist, induce withdrawal bleeding, and then it is conventional. Gonadotropins, start the antagonist at the right time, give HCG or agonist, and move on. That is all well and good if the patient comes at the mid-luteal phase. What if the patient has just missed the boat? She's seeing you on day 7 of a menstrual cycle, and now you have to wait for the luteal phase before you can give the GnRH antagonist to cause the luteolysis. So in this model, you see the patient on day 7. You see, let's say, a 15 millimeter follicle at that time. So she already has a lead developing. What you do is start the gonadotropins, because here, sorry about that. So here, what is very sensitive. So I cannot use this. Okay, so here, what you do is start the gonadotropins right away. Well, hang about. Is this right? Right. So you start the gonadotropins right away, and sorry, I have gone way ahead. Okay, late follicular phase. So this is the late follicular phase. Patient comes to see you. This is, say, day 7 or later. You have a lead follicle that's already developing. You ignore it and you think about the wave of follicles, secondary follicles that are already developing at the same time. The aim is to develop those follicles. So you use the gonadotropins, wait for the spontaneous LH surge to occur, which it will, and then looking at the second follicle that is following the lead follicle, when that reaches 12 to 14 millimeters in diameter, start the antagonist and move on, basically sacrificing the lead follicle for all the other follicles in order to obtain adequate number of oocytes. So then comes the next question. Why am I waiting for that spontaneous ovulation to occur? Why don't I just give HCG and force the ovulation and then move on fairly quickly? Because otherwise you're waiting for the spontaneous ovulation to occur. So again, the same scenario, only difference is as soon as you see her, you give her HCG at that 15 millimeter follicle size and start the gonadotropins, then aromatase or inhibitor and GnRH antagonist, and move on. So at this point you can say, okay, we have come to the point of now we are starting the gonadotropins in the luteal phase. We're back to square one. We started the luteal phase and we saw the patient for the first time. We gave a GnRH antagonist to cause luteolysis and then wait for the periods to start the whole process. So in reality, you do not have to wait at all. You see the patient, whatever be the phase, you just start the gonadotropins and move on, and you could ignore the actual lead follicle. So is there any evidence that this works? Absolutely, there is. So here's a paper published in 2009. It's a multi-center trial by one Wolf. What they did was they took 40 patients who were obviously presenting with diagnosis of cancer, and 28 of them were eligible to get into a conventional antagonist protocol. But the other 12 patients were in the luteal phase. And what they did was they just started them on antagonist as well as FSH at the same time and moved on. And what they showed was the only significant difference was that these patients who were started in the luteal phase needed significantly more FSH, which makes sense, than the patients who were in the conventional arm. And here's another publication in 2010 where I am highlighting this only because they have case reports and we can actually follow exactly what they did. So first case was a 31-year-old with carcinoma of the breast. On cycle day 17, they started her on antagonist as well as FSH and recombinant LH. You could give HMG instead. 75 days, and 7 days of stim, patient had 11 follicles greater than 17 millimeters. 13 oocytes were obtained, 11 were mature, and 7 embryos were cryopreserved. And chemotherapy started mere 17 days after the first initial visit, which is fantastic. Case 2, 24-year-old, no partner, Hodgkin's lymphoma. She was able to start her treatment cycle on cycle day 22. Again, they gave her ganirelix 0.25 milligrams and FSH 225 daily. And what they ended up with was 13 oocytes, 12 mature, and cryopreserved. So this illustrates that you really do not have to wait to start your cycle treatment. It's sort of smoke and mirrors because for us, any advance or any innovation we make, we like to take them in steps. It makes sense. You don't want to take a big step, big jump. But what is evident from this is that you do not really have to follow the set idea of having to start at the early follicular phase. It is very similar to that big jump that people had to make in terms of oral contraceptive pills. We had that withdrawal every month and it mimicked the regular cycle, and today you say you can take the pill continuously for years on end. So we need to make that mental jump to move forward and make the statement that these patients don't have to wait. We could just start them and we could just ignore, because follicles are developing at all times in the ovary. And the idea is that if we just go past it, the big advantage in these patients, we can't obviously do this for all our patients. The reason why we could get away with it in these patients, they are not going for embryo transfer because we don't have to worry about the endometrial status at all. Therefore, in these patients, it's very ideal that we could really random start a cycle at any given time. So in summary, antagonist protocol is really the protocol that you should follow for all the patients with diagnosis of malignancy. Follicular development occurs in waves, so be willing to sacrifice the lead follicle of the current cohort and think about the other cohort that's following it. You could start antagonist only after the lead follicular diameter of cohort follicles you're monitoring reaches a 12 to 14 millimeter diameter size. That, if that gives you comfort, and certainly Mitch Rosen and Chuck Muck's paper alludes to all the evidence behind that, clearly proven. But there are these two case reports which allows you to even move forward without undergoing all that, waiting for LH surge to occur or giving an SCG to move into the luteal phase. You could certainly move forward right away with starting an antagonist together with an FSH, preferably HMG, because you want an LH activity at the same time, and then following the cycle as you normally would. So that's what I would suggest based on the evidence I've shown you. So shifting gears to the special case of ER-positive breast cancer patients. You could use tamoxifen, or you could use aromatase inhibitors, the options being letrozole or anastrozole. So tamoxifen is a SERM, and it can be used at a dosage of 60 milligrams a day with or without a FSH. In a natural cycle compared to tamoxifen alone, the embryo yield was 1.6 versus 0.6. All the studies, by the way, are from Oocytes in Cornell. And tamoxifen alone versus tamoxifen and FSH clearly resulted in a much better embryo yield and has the best. But if you look at the use of letrozole, it reduces the estrogen levels, which is far better than just blocking the effect of estrogen on the receptors. So you don't know if the ER in the breast is going to be effectively blockaded by the tamoxifen, although it should. Whereas truly decreasing the estrogen level makes much more sense to me. If I were the patient, I would prefer that than just having a blockage of the receptors. And it does result in a significant reduction in the peak estrogen levels. An average is about 1,000 picogram per ml less compared to patients who don't take letrozole. And also, it interestingly significantly reduces the amount of FSH that is required for the cycle. And even more interesting is the fact that the embryo yield is much better than if you use tamoxifen with FSH. So the letrozole arm contained yielded 5.3 embryos as opposed to 3.8 embryos in the tamoxifen and FSH arm. Anastrozole, on the other hand, even at maximum dosage, did not suppress estrogen as much. Therefore, use of letrozole in conjunction with random start protocols is the best method, in my opinion. And the second best probably is tamoxifen, and anastrozole use should definitely be avoided. What about those young patients who are prepubertal? Nowadays we have so many patients with hematological malignancies coming at a much younger age. Can we give them any hope? These patients can have, and these are not the only patients who require ovarian tissue cryopreservation, though those are patients who probably would need it most because they have no other option. But in all patients, it can be performed simultaneously with oocyte retrieval. So you don't have to do it as a separate procedure, though it can also be performed first, followed by COH, or it can be performed simultaneously if you're going to do in vitro maturation as well. More than 20 births, actually, when I made the slide 20 births, but I know that almost 30 births have been reported using this method. So it has still to be considered as in its infancy, unfortunately, and many labs cannot handle cryopreservation of the ovarian tissue. And listening to the lecture this afternoon, apparently in India at this point in time, nobody's got the expertise to cryopreserve ovarian tissue as of yet. But where available, this is certainly a very important option to provide to the patients. The biggest concern, however, is what if the cancer cells, especially hematological malignancies, could be lurking in these ovarian tissues as well, and by orthotopic transfer, you could give them the malignancies back when they are in remission. To date, nothing has been reported to that effect, so it is considered unlikely, though it is, I guess, not impossible for that to happen. Only time will tell. So what about success rates? What do we tell our patients? You know, we don't want them to go home thinking that they have a 100% chance of retaining their fertility if they were to go through this process. The only paper that really looked into it, and which is not the best in terms of robustness of study protocol, but the best you can get under the circumstances, is the GREECOT study. This is a French study group for cryopreservation of ovary and testes. What they did was they sent out a questionnaire to 97 IVF centers around France with a 54% response rate, which is not too bad for questionnaires, because what they asked for was a lot in terms of data. So they collected data from 1999 to 2011. 52 patients had undergone 56 cycles, and 53 were successfully completed. And what they showed was, on average, patients had 6 oocytes retrieved and 4 embryos cryopreserved. And so that's something to tell our patients. On average, they have the possibility of having only 6 oocytes and 4 embryos cryopreserved, though personally I've seen way more in some very young patients, but that's an average to quote. And 49 of the 52 patients survived cancer over this period of time, with 22% of them eventually opting to have embryo transfer done. So that's roughly 1 in 4 or 1 in 5. 27% had a live birth rate. So that is pretty good, but that's the reality of what we tell the patients, that maybe you'll have 4 embryos cryopreserved on average, and the chance of live birth is 27%, which is not bad, but at the same time it's realistic, so the patient doesn't think that she has these embryos and she'll 100% get pregnant afterwards. So I don't have success rates for live pregnancy in the meta-analysis, and that's why I'm showing this later. So meta-analysis of 7 studies by Friedler in 2012, which include studies from Pal, Oktay, all the way to Robertson, include 227 cancer cycles and compared it to 1,258 control cycles. And what they showed was oocyte was, statistically it was significant, but I think 11 oocytes over 13 was not bad at all, but only 9 mature oocytes. So again, 6 in the other paper, 9 here, somewhere in that ballpark. There was no difference in fertilization rate between the groups, but pregnancy, they could only talk about 20 patients that they had in these 7 studies. So out of 20 patients who underwent FET, 10 deliveries occurred, which is not bad, with 2 ongoing, 1 ectopic, and 1 biochemical. So from a success standpoint, realistically, I think 22% clinical pregnancy live birth rate for these patients is actually a very reasonable number to give. 6 to maybe 9 oocytes and 4 or 5 embryos cryopreserved is probably the reality of what they will get. So in summary, COH must be performed before the first dose of chemotherapy. The phase of menstrual cycle determines the type of protocol or not. So it may be necessary to wait for dominant follicle formation before starting the antagonist. I mean, it may not be necessary, and that would be my advice to you, to not wait for it. Letrozole is the preferred drug to reduce estradiol levels if you have ER-positive breast cancer, and avoid anastrozole, and success rate is not too bad. Thank you very much for your attention.
So you can start it anytime, even if there's a dominant follicle. Is it post-ovulation only? Because there was a recent study which was post-ovulation, you start the letrozole.
Letrozole you start in conjunction with, if you're are you talking about letrozole use with
the FSH for a random start?
For a random start, you missed the sequence.
I'm very sorry
I'll be
that.
happy to talk to you about that and show you the sequence. It's very, very interesting. I will be happy to share that with you. But essentially, to cut to the chase, what I am advising is to just start the patient on antagonist and HMG or FSH and recombinant LH simultaneously right away. You see the patient, you get it ready, and 2-3 days, whatever it is, you start the cycle right away, blind. It doesn't matter what stage of the menstrual cycle they are at. It really does not matter, and that's the evidence I was showing.
And with letrozole?
So the letrozole is only for, if you're going to use letrozole, it's for patients with ER-positive breast cancer. In those patients, you add the letrozole along, again, start it all together at the same time.
That paper which I read, the letrozole, they said why they're giving they give letrozole for the first 4 or 5 days to bring down the estradiol level. Then the HMG stimulation acts better.
Right.
I mean, that's what the paper was saying. So I don't know.
Here's my personal take on, so the whole thing about using letrozole to bring down the estradiol levels in these patients was brought about by Oktay, Kutluk Oktay from Cornell. He clearly is the pioneer in this field. He started the whole thing. But I seriously suspect, knowing how IRBs work in USA, he had to go through IRB to do the study. And I suspect that the lay people in the IRB panel were very afraid that we are going to incredibly increase the estrogen levels for 10 days in these patients, and in 10 days, the breast cancer is going to bloom. We all know breast cancer is a very slow-growing malignancy. It is impossible. So it's basically, we are just kidding ourselves, in my opinion, by trying to reduce the estradiol levels for 10 days in these patients.
That paper didn't mean was not restricted to the breast cancer. What they said is, in the stimulation protocol, if your estradiol levels are lower, that will cause the more follicular recruitment. They got more number of eggs when they use letrozole for kind of down regulation of the estradiol level.
So you're talking about estrogen priming.
Yeah, estrogen priming.
That's terms of
why
trying
they use that.
Sure. But the thing is, we don't have the luxury of time in these patients. And that was the point I was trying to make, is most of these patients, the oncologists are really behind you, asking to start the chemotherapy yesterday. So that is the real problem with these patients. You do not have the time. If you have the luxury of time, let's say the patient has a slow-growing sarcoma and you have the luxury of time, you can certainly do the conventional protocol that you are comfortable with. But when time is of essence and it's pressing, then just a random start with antagonists and FSH at the same time, and then adding, going for the retrieval when you're convenient makes more sense.
This is just for information. You said about the ovarian tissue freezing. We had Klaus Anderson fly down, and he's frozen 2 patients in our unit in Bombay.
Oh,
and,
I'm sorry, I misspoke.
Rectal carcinoma. One
but
of the patients
this is the information I got at the
carcinoma. And he's amazing. I mean, he's really amazing.
Thank you. Very nice and comprehensive presentation. Just an anecdotal case to support what you just said, and I 100% agree with it. 2 months ago, 42 years old patient, about to start chemotherapy within 2 weeks. She was referred by the oncologist on the 7th day of the menstrual cycle, FSH 22, 42 years old. Just one 12 millimeter antral follicle. Nevertheless, we started knowing and explaining to her the very, very low possibilities of retrieving oocytes. We started with antagonist and pergoveris, recombinant FSH and LH. By mistake, she took, together with these two, on the first day of stimulation, she took the HCG shot. Oh. Nevertheless, HCG shot, HCG injection. So surrogate LH surge. Nevertheless, we continued, and after 7 additional days of stimulation, we were able to retrieve 2 oocytes, both of them fertilized, and 4-cell embryos were frozen. So the artificial HCG does not necessarily compromise the quality of eggs.
Thank you. Appreciate that. I think you had a question.
Yeah, I have a patient who's got sarcoma, and she's been given just 1 month to plan her surgery. So my concern is, I'm not very sure whether letrozole would be the drug of choice or whether the conventional protocol.
So what I just said, I would go home, start her on antagonist tomorrow, and start her on HMG at the same time. And 7 days, these studies, they're all saying 7 days, and you have plenty of oocytes ready over 14, 15 millimeters.
Yeah, it's not an estrogen-dependent tumor, so
no.
We could use the conventional protocol.
Yeah, you don't have to use letrozole at all. Okay. You just need the HMG and antagonist, and then HCG when she's ready, and go for retrieval.
Okay, thank you.
Thank you very much.
Excuse me, could I ask a last question?
Sorry, yes.
So regarding the letrozole issues, does it make any sense to administer letrozole in the luteal phase? So I mean after the oocyte retrieval, because this is something that was also mentioned by Octai, in order to keep the E2 low after the oocyte retrieval.
Until it reaches 500.
We do this, we continue the letrozole, but
if you, yes, absolutely. I must admit that I did not make that clear. If you're going to use letrozole, then the Octai protocol is to continue until it comes to less than 100 picograms per ml. So it's not how many days you use. You keep monitoring the estrogen level until it drops below 100 picograms per ml, and then stop the letrozole at that point in time.
Okay, thank you very much.